Okay, thank you for having us today and for the invitation to come and talk about our services and how we can support. As Claire said, I'm one of the team leaders for Dementia Support Australia. I am based here in not so sunny Queensland in Brisbane. So, as we're facing Alfred's arrival this week, I'm very much hoping my power and internet hold up for our chat today. So this is what we're going to be covering. We'll briefly go through what behavioural and child and psychological changes we see in childhood dementia, how we at DSA approach these cases and how we can support. And my colleagues Belinda and Catherine are going to jump in as well to present a really valuable case study. And then we'll cover how to refer and what might be the best time to refer. So, as we all know, childhood dementia is associated with several highly complex genetic conditions, and it isn't a disease in and of itself. It affects multiple organ systems, and I'll speak more soon to specifically the cognitive and behavioural changes that happen. For this reason, there are often multiple specialists involved depending on the systems affected. And again, due to the complexity, there can be quite a delay in receiving a diagnosis, which presents a really stressful time for families. They can often receive initial diagnoses of things like autism, seizure disorders, visual impairments, and it does take time for those dots to be connected and childhood dementia to be identified. There does seem to be a growing awareness, though, of these groups of conditions. So, summarizing it all, childhood dementia is that global progressive neurocognitive decline with multiple developmental skill loss during childhood or adolescence, usually following a period of typically normal development. And this slide just gives a bit of a visual representation of that, of how development looks different. So, usually from ages 5 to 6, children start to regress and demonstrate those changes in their mobility, their speech, their cognition, which often varies from that normal trajectory of skill acquisition. Parents, of course, become concerned with these symptoms as they appear and they see troubles at school, trouble sleeping, and that's usually when they start the journey of getting a diagnosis. So, speaking more about those symptoms that are in the category of behavioural and psychological symptoms, or BPSD for short, these include things like anxiety, attention, poor attention, and behaviour changes like being uncooperative or disruptive, which are then at those times usually diagnosed as things like autism or learning difficulties initially. So, how can DSA support? Well, especially with all the services and specialists that are involved with these families, where do we fit in? How can we help? So, DSA supports families with children living with childhood dementia, and that is of any age, adolescents to young adults. We have trained consultants who understand childhood dementia, the related symptoms, and the impact it has on those affected, both their carers, the child themselves, and families. So, our role is to provide tailored, practical, and non pharmacological strategies designed to support the school and the families caring for that child. So, our focus is improving quality of life through those strategies that aren't medication related. That's what I meant by non pharmacological. So, what we aren't able to assist with is things like NDIS and funding applications, but we do work closely, as I said, with those specialists that are involved and other services who might be involved that might benefit from some advice around change behaviour. So, this is our model of care. This is how we approach cases. Our goal from the get go is to identify the causes of the change behaviour rather than focusing on on the symptoms themselves and providing non pharmacological strategies to assist in managing those behaviours. So, those underlying causes could be related to various things, but some examples include pain and discomfort, over and under stimulation, or perhaps how the child's being approached or communicated with that could be adjusted slightly. But I'll elaborate on those shortly. And as I've said a few times, we do rely really heavily on that collaboration with the child's family, the allied health teams, the schools, whichever parties are involved. So again, here are some common factors that can contribute to change behaviour. So firstly, we generally don't think that children experience pain. Perhaps it's something we associate more with older adults. but we always evaluate if there could be unmanaged or undiagnosed pain. This could be related to position, like if the child is needing to use a wheelchair and doesn't change position regularly, things like headaches from overstimulation, whatever the cause may be. Secondly, carer or educator approach. So we know that these families are really heavily supported by NDIS that come with a really strong disability lens. But what our team provide is that unique dementia lens. So we support those involved to consider the impact of dementia on the behaviour and whether the approach needs to change, perhaps maybe shifting from more of that reablement, restoration of skills approach to more of an approach that avoids overwhelm and managing fatigue and discomfort and things like that that could be underlying changed behaviour. Visual and sensory changes are really common. The child can develop impaired vision, become really sensitive to light or sound or water, those sorts of stimuli. And this means that they can be really easily overstimulated in the classroom environment. That may be compounded then if they have therapy sessions after school or like a busy timetable. So our team can help the caregiver sort of adapt maybe their routine to manage those changes. And lastly, I'll just touch on constipation. These children experience a lot of gastrointestinal changes. Their gut function can also be affected if their mobility has changed and they're moving around less. And that discomfort can then contribute further to change behaviour as well. So these are just a few examples.